Oh, basically, dear all, welcome. You can put in the chat box all your opinions, and I would be seeing and on real-time basis. And more than just presenting to you some of the slides, it will be more or less very interactive, as much of discussion as you want. The very purpose of this course is knowledge, not just certification. And the most other outcome is that tomorrow you should be able to seriously practice asthma and allergy. So that is the objectives of this course, and we will start. There are two parts of today's session. The first would be about the course, and second would be I'll be telling about asthma and allergy overview and what will be the contents of the course, etc. How we are going about it, and also about asthma and allergy. So you will have some fair idea of how we are going about it. In the first case, I will just know I'm audible and visible, and is it fine for all of you? That is just to know. If any one of you having difficulty in seeing, or if you have any technical difficulties, please let me know. All this no recordings will be shared, and if you want the slides to be shared, I will just think as to how it can be done. Dr. Raghav. Okay, no issue. We have no issue in sharing anything. Please understand my point. Only thing is that you need to keep it confidential. You should not it should not affect, it should not be secondarily broadcasted to somebody, so that instead of joining the course, okay, I have the slides, I will see. But the point is, it's agreed. I have no problems with that. But the question is, they will neither read nor they will join. Only if you have aligned, and if you have paid, and if you are inside, then only you will be serious about a course. Okay, fine. I'll tell you about the course first. See, let us understand what are the objectives and why this course. Are there not courses? In fact, the basic advanced asthma course in respiratory chapter was my brainchild, and it was my dream project for which I worked for nearly 4 to 5 years. And it was done, and some of you must have already done that course, some of you must be doing. We are into 8th or 9th batch of that. So that is a very successful course. And I also saw some courses of allergy. Now, there were some demands for me of late, because I was not actively invited in most of the sessions of asthma and allergy course. There has been huge demand from many groups telling that, sir, you please teach us asthma. So please understand, it was kind of a lot of compulsions from the people. Whenever I met in conferences or online in other courses, they said, plus, sir, please start your course on asthma. We would listen to you. So, but my point was, let me start with a disclaimer that I'm not actively practicing allergy testing. Allergy testing is done by somebody else, and I will just refer. And therefore, I have involved one person from the faculty of allergy side, and he would be taking around 3 or 4 sessions only, and nearly around 20-25 sessions will be taken by me. So this is how we are sharing the protocol. So majority of the sessions will be taken by me. All about asthma comes from my side. So this is what is the um, um, plan with which you are doing. So you will be able to appropriately make diagnosis of asthma, assess the severity. You will be able to do evidence-based management. That's why I gave you that GINA, which is one of the very good evidence-based management guidelines. You will be empowered with inhalation therapy skills. A lot of videos are there with me. I can share with you how correctly you should educate regarding inhalation techniques, therapy, everything, and aerosol therapy and all that. You will have integration with allergy, like basics of allergy and also about allergy practice. You will be learning about long-term care and prevention, and you will be having something which is a new thing in this course, which is not there in most of the cases: office practice readiness and empowerment. That means none of you will be telling, sir, I can't practice asthma at the end of the course. If it cannot be completed in 6 months, I don't mind extending couple of sessions more, because last time, even for the X-ray course, we thought that we'll finish in 3 months, but it went up to 5 months. So there is a stipulation and guideline, but it is not necessary. If any one of you feel that, sir, this particular topic is required for us, we are here to teach you. We are not here to deprive you of any of the learning contents. I'll be sharing the contents, and I'll be sharing the contents in the group also. If you want any small little modifications, or you want something more or less of a particular topic, please tell us. We are ready. For example, if I have a session on pulmonary function tests, and if you want more sessions, please tell us. We are ready. So this is how we are going. Are you all okay? Please type okay. I want you to be even content guider, and it is need based. Need based means, because all of you are in different layers of learning. Some of you must be already very good in your particular field. Some of you may be already practicing. You can give your inputs. Absolutely no problem. And you please feel free and ask more. So that's very, very important for all of us. Okay, right. Very good. Nice. What you learn in diagnosis. See, what has happened in the past is IAP was giving guidelines. And from where the IAP was making, how IAP was making guidelines. Even I was involved in guidelines making. IAP was importing the guidelines from rest of the world, while it was having some of the studies from India, or some references from India, some good practices from India, some publications from India as well, and integrating, and ultimately giving some kind of hybrid product. Now, what I felt was, when it comes to going for Pakka, very good studies with evidence base, I think we should stick to GINA guidelines. I'll come about that why, and why this deviation was taken, and let me talk about that as well when I came to GINA guidelines, and why we are sticking to GINA guidelines. Let me also elaborate for you a little later. So asthma is all about identifying and recognizing, which means yes, it is asthma, which is diagnosis. No, it is not asthma. Mimics. Yes, it is asthma, but how severe it is. Basically, it's called assessment of severity. Okay, how should I manage? And how should I monitor? How should I follow? And how long should I follow? These are the basic questions you will ask in diagnosis and assessment. As far as evidence-based management is concerned, I think the basic thing, if you are a soldier in military, you should be disciplined. If you are practicing asthma, you should not make your own personal style of practice. That is because already asthma is heterogeneous in management and confusing. If two pediatricians start managing in different ways, definitely mothers get confused between two pediatricians. Let's say somebody from Lucknow migrates to Bangalore for the sake of job or for the sake of school, then she should not get two different versions from two different people, provided both of them follow the same guidelines. And what is most robust and updated as on today is GINA, and GINA doesn't belong to any country. It belongs to groups of countries. And therefore, whatever that is there as evidence-based summary. See, you may say, sir, GINA has not covered this. That is because, yes, it is a point, but it has not reached up to the level of evidence that the GINA can write it up in its pages. Are you all understanding what's this GINA? GINA is basically groups of formed from groups of countries and taken from all recent evidences. There will be some a methodology by which they will reach to some kind of consensus. and as a draft or a document, it get released in the first half of the year every time. So we would be wishing that the new JINA guidelines 2026 will also come while we are in the course. And whatever little modifications happen, they will be add on or updated to our course as and when we are moving forward. Right now, we'll be following JINA guidelines 2025. Okay. Will there be difference between 202, 2022, I mean 21, 23, 24, 25, 26? Not major. There will be minor modifications, and I'll tell you when I come to JINA again. The next challenge for us, which is not given in JINA guidelines, is inhalation therapy skills. This is what I meant by empowerment. A lot of theory is being taught in inhalation therapy, but when you get a multi-halar or a newer device, actuator, or a newer DPI, or some newer formulations, you will start blinking. It should not. And how it should be preserved, used, maintained, for you to tell the mothers, you should be knowing first, and the mothers are going to measure the confidence levels of the pediatricians whenever they meet. If you are knowing correctly, then you can comfortably and confidently convince the mothers. And this is very, very important. Now, the next part is we saw, at least in the last decade or so, I saw the science of allergy is growing heaps and bounds on its own. And non-allergy pulmonology is also growing on its own. By even from Indian Academy of Pediatrics, by two separate chapters with no common members. And it so happens that many of the guidelines given from one perspective may have some deviations from the other. Generally, no. Please understand my point. The level at and the area or the tire level at which you place in your thoughts as a part of your algorithm or protocol may become different. So we are going for some kind of integration of allergy practice, allergy immunology practice, and inhalation therapy practice together. Did you like this integration? That is what I meant by empowerment. Should not say, I am an allergist, but I am an asthma specialist. It should not happen. You are both allergist and asthma specialist. Integration is the way, and there should not be difference in the type of practice. Long-term care, prevention, and what is most beautiful, it will come at the end. Office readiness, and I would even go ahead and take a survey as to how many of you have started an asthma clinic. Mind you, immunization is gone for pediatricians. Literally, refrigerators are drained out because most of the vaccines are given by the government. And newborn care is taken by the corporates and neonatologists. And what is left for a pediatrician is a respiratory practice, which consists of 50% infections and 50% non-infectious, or 80% infection, 20% non-infections. And it is there glaring in front of you what is the practice that is available to you. Here I have three types of pediatricians. One who is going to manage respiratory illnesses because he is a pediatrician. URTI, LRTI, visas, foreign bodies, everything he sees and manages at his own competencies, and he either refers or he co-manages, but somehow he manages. The second layer of pediatricians who are interested in pulmonology, which all of you, I'm telling you, all of you have joined for this course, are the ones who are having passion to pulmonology. Some of you are certified, some of you are not certified. It's all right. How does it matter? But you want to do something more than the general pediatrician. Somebody is not doing spirometry and you want to do. Somebody is not doing allergy testing, you want to do. This is what I meant by empowerment. Somebody is not using PFR charts, you will start using. Somebody is not even prescribing a peak flow meter, you will start prescribing. Somebody is not managing comorbid conditions properly, but you start managing. Are you getting my point? You will be with some difference from the general pediatricians. Now, third category is some of you may become excellent hardcore pulmonologists. You are at the peak level. You are an interventional pulmonologist, DM pulmonologist, or already fellow in pulmonology, or a teacher of pulmonology, etc. This last category, you may be also doing something like bronchoscopy, sleep studies, so on and so forth. If any of you are there in the field who have more knowledge, please kindly accept my apologies in the sense I may not be catering to that level of so-called advances, controversies in the field, etc. I would focus on this middle layer. Mid layer means pediatricians with interest in pulmonology wants to get empowered and do the respiratory practice. Are we okay? Please type okay. If you want me to little upscale this to the level of high-end pulmonologist, I'm okay. But please understand my point. Then I should not lose the rest of the crowd who are listening to us. What I felt was most of you will practice pediatrics, but will set up an asthma clinic. How to set up an asthma clinic? Okay, before you are confused, let me give a point to you. For example, you will say, sir, Tuesdays are very weak days of my practice OPD. Okay. Or you will say, sir, between 2 p.m. to 5 p.m., I don't get any patients. Agreed. So therefore, what happens is you can have a dedicated slots in your office for pulmonology practice only. Start pooling patients and seeing them at that time. I don't know. Did you understand my point? Let's say Tuesday, you can put a board on your clinic and then say Tuesday 2 p.m. to 5 p.m. I will see all pulmonology patients. Suppose you get a patient on Friday, you will see them and then invite them next time, pull them and call them on your non-busy days. Does this not make sense to sort out the patients from your practice so that you will not lose temper? You'll be able to counsel and even you will be updated. For example, you can have your machine ready for that day. You can have the sister having that everything. Now, advanced level of interventional pulmonology will also be taken. And then what I will do is, if you want advanced pulmonology from me, what I will do is, after this course is over, you, some of you can express your interest. Sir, I want to do some more advanced level. So I can do one thing. I can just take a 2 months or 3 months course with very, what you call some kind of upgradation from the existing level. But I want you to know what is advanced level. Advanced level is about knowing more and more about basics. Let me tell you. Let me give an example and make you understand what we mean by advanced level. You will see pulse and blood pressure as an undergraduate student. Yes, you explore with a white coat as to how to examine the pulse and blood pressure. You will enjoy. But you examine it as an intern. At that time, you will feel, oh my God, this is pain to examine pulse and blood pressure. As a postgraduate, oh my God, I have to write some BP, pulse, blood pressure. As a consultant, oh my God, if I don't take pulse and blood pressure, I may not be able to sleep tonight. No, it's a must in ICU. You might have drawn so many conclusions. Now, when you are a cardiologist, and when you take the pulse only, I will leave the blood pressure. The way you see the same pulse is different. This is what I meant by advanced level. I have never gone to any intervention. Please understand. I'm not talking of echocardiography. I'm not talking of cath lab. It is even about pulse, taking a pulse. Now, first of all, let me tell you, this type of advanced level I will empower right now for you. To understand a pulse, you don't have to join advanced course in cardiology. I will empower it right now for you. The way you approach asthma, the way you understand asthma, the way you start interpreting asthma and its management, you don't have to go for the so-called advanced course which I'm talking now. No. That is for some of the things which are very, very difficult, maybe for Mumbai, Delhi, Bangalore only, or Kolkata only, and things like that, which are not there for most of the cities, exceptionally high end. You please do not worry about them. That also we are ready to teach. We will find a way forward. But after this course is concerned, so you will be missing only 1 to 5% of something in pulmonology, uh, asthma management, um, probably. But we will see that as much as possible of that is also covered. So somebody put up the message 80-20. So I'll keep 80% to cover everything, 20% here and there will give you some of the ideas. For example, tiotropium, uh, monoclonal antibodies, how to use them, to be used or not to be used, all these things. Understand? You will do. But will you practice or not? I will leave it to you. Okay. Now, this is about the course. Next, this is the tentative timetable, and I will share with you in the WhatsApp group as well subsequently. See, it contains the following sections, and if you have anything else to suggest, you are most welcome. Don't read the topics. There will be introduction, which I am giving you today. It is not introduction to course. It is also, it will be followed by introduction to asthma. And why did I write tentative? It is because you can even ask for more or less of something. Next, basics means there will be basics of asthma, basics of allergy. This is something called as anatomy, physiology, cells, cytology, so on and so forth, uh, allergy behavior, asthma behavior, etc. This would give you some kind of idea because you need a starter. So that will be covered by one basics by allergy by Manjunath, and etiopathogens of asthma will be covered by me. Next, there is something called applied basics. If I What happens is if I go for step care management of asthma in future, you will not be able to focus on certain basics like drugs, devices, inhalation, therapy, functional tests. No, there are two slides, Dr. Jayashree. Don't worry, this is not over. There is one more slide. So, um, um, case scenarios and skin prick test. What I mean by case scenarios, drugs, devices, inhalation therapy, pulmonary function tests are done. It is followed by one exclusive session on case scenarios. There we will apply whatever you have learned. Whenever there is a case scenarios, it means you will apply and learn. This is what I meant by empowerment. Did you understand the point? Now, PFTs are done. After that, we will discuss the PFTs and we will all start doing interpreting the PFTs, and there'll be on skin prick test as well. These are again basics, but this is something like extended basics: drugs, devices, inhalation, PFT, skin prick test. All right. Okay. Next, we'll come to management of asthma proper, which involves diagnosis, which is symptom evaluation, age wise, below 5 years, above 5 years, management of about 12 years, multimorbidities, and case scenarios again. Case scenarios means it is not that just we'll give a case and you can also discuss your cases. When I say case scenarios in diagnosis of asthma, we will not have case scenarios related to therapy there. Only case scenarios related to diagnosis of asthma will be discussed in that. As much as possible from real life situations, we'll try to take. We will not take up the cases which are cooked up as much as possible. But however, if I want to complete something and there is no case prototype saved in my laptop or in my dictionary, then I'll pull it up from the uh, colleagues online, etc. Now, assessment and control of asthma, it involves again severity and risk assessment. You will learn by applying in case scenarios how to assess and identify the risk of an asthma. This is again will be taught to you. Next. This is the page 2 of the same. Actually, it is only one page, but for you to see on a screen, I have converted them into 2 pages. Long-term management. Management includes long-term management. Some high step management. This is what I meant by coming in 80-20. 20. Difficult to treat asthma. In the 80, we'll have acute flare-ups case scenarios, SCIT, subcutaneous immunotherapy, follow-up of the patients, including how to educate the parents and empower them for self-management and prevent it, including environment control. Again, case scenarios in the management. Last, most important, which is very passionate, setting up of an asthma and allergy clinic and ordering and doing PFTs. Even I am in conversation with one of the companies on spirometry and trying to bargain a kind of price that all of us together. I will invite him on Zoom and then all of you can bargain together and decide, fix the price and then go ahead from then onwards. And then summary will be like almost like on the lines of something like what you have undergone an asthma training module one day. So it will happen. And on that day, it will not be for 1 hour. It will be for 5 or 6 hours of summary. You would have learned the entire course. Lastly, you will learn what general pediatricians are being taught. So every word, every line, you will understand better and better. And then there will be examination, which I have not declared the date because I'm not sure whether we'll be able to exactly come and complete in the timeline. Because for examination will be online. And if you would wish to have some practical contact sessions, I may do it in more than one place for you. Some people are asking do in Bangalore, or do in Delhi, etc. I don't mind doing in 1 or 2 places, one in north, one in south, or wherever you would wish to. And if any of you volunteer, sir, I have got a place, my clinic can be the place, and there is a nearby hotel where the people can come. But I am practicing um, PFTs and skin prick tests, asthma clinic, etc. You conduct a course in our place, let others come. Please volunteer. Somebody is in Ahmedabad, somebody is in Jaipur. You understand my point? You can volunteer, but you need to plan. And to this extent, I'm open. There is nothing like this will be on hand to mouth basis. Whatever expenses come will be shared amongst the participants, and then we can close from there, food, etc. Whatever that small things that come, as much as possible, we'll try to do it. If it is in my institution, certain things I can take care, but if it is outside, then I don't know. I don't have a control on the institution sponsorships, etc. But I will try and negotiate, and then see some institutions can also come forward. We'll try to see that later on. We have a lot of time now because it is somewhere in October. Now, are you all happy with the contents? Anything else? I will just scroll it for you. At least give me a brief idea. Basics, applied basics, diagnosis, assessment and control, management, empowering, and some summary conclusions and an examination. I would wish to do actually periodical examinations. Means every session or every 2 sessions or every section we will do. Effort is there. Effort is there. PFTs means effort is there. Okay. I did not write FOT. I don't know. Pulmonary function test will include FOTs. How to do PFT read it? Will it be covered? Yes, it will be covered. ER and food allergy. ER will be covered as multimorbid conditions. Food allergy we will not cover. Most of a more of a practical needed. Yes, it will not be theory at all. FOT, impulse oscillometry, will be covered. Don't worry. Skill course in skill allergies. Skin allergies. Yes, skin prick tests are there. See, basics of allergy, skin prick test will be there. Inhalation therapy, dosage in under 5. Yes, it will be covered. Immunomodulators, drugs like azithromycin will be covered. Yes, no problem. Drugs and devices are there here. Yes, anything else? Just keep typing. I just need to know. You don't worry about correctness of what you are typing. Contact session also, I will arrange a vendor to buy spirometry and PFT. Even online also I will do. I'll try to fix a vendor or a sponsor so that you will be able to make a choice. All right. Blood test for allergy. Yes, it will be covered. Upper respiratory tract allergies. Yes, it will be covered. I just wanted to know your input so that when I can easily, I have got a lot of slides on asthma already, which we have taken in past 10, 15 years. You can easily modify to whatever your requirements are also there. See, it is very easy to modify and we need to do some hard work and prepare that. Okay. Recordings. I'll come to that point. Shekhar, I'll share with you 1 second. Now, how to set up the asthma clinic and cost everything. It is not about, see, let me assure you, if you are setting up the clinic, we'll give you print PDF so that you can print them and keep. Suppose PFR charts are required for you, we will give you. Contact sessions will be kept, but contact sessions will be like, we'll work it out later on. How many will come? Pheno you want, okay, done. Skin practice in detail, okay, we can practice at your place, it will be done. Skin prick test, as far as skills are concerned, you can only learn during contact session. You got my point. I can tell online prick like this, etc. But for you to practice it, you will really need to come and do it and give your inputs regarding um, contact sessions. I'll try to contact in next 1 month and see if somebody from elsewhere. First of all, let me see all the participants and do you all agree? And the area of distribution from where they are coming, north, south. I mean, if I take the distribution of the places from addresses from where the participants are coming, closer to their areas, I can cluster them and then see environment control, etc. will be done. No issues. Pollution, etc. Done, done, done. That will also be done next. It's fine. Good. I got an idea of what all you want done. No problem. Next. See, all participants will be on WhatsApp group. Those of you today who are listening to me who are not on WhatsApp group, please take this number. 1 second, let me tell you some of the things, like take this number for me of Salma. Salma is our office secretary. I'll give her number to you. I think you have. Most of you must be having. Still, I'll give you. It is there in the payment link page. I'll type again 8121624242. Number which has come in the message chat is Salma. Her name is Salma. She is our office assistant. Please remember one thing, that our office assistant doesn't work on Sundays. Now, please keep, no, contact place, everything will be planned in advance. Please don't worry. Now, Salma will not be working on Sundays because Sunday is a holiday for, she's a clerical staff, office staff, so of mine, so she works on all the days. Please understand my point. And she works from 9 to 5. If you have posted after 5 or on Sundays, repost on the working day any message. Is that okay? Don't say, sir, your office is not responding, etc. Usually she comes in the morning and sees all the messages and clears and she updates me. once. Please understand, so there is a lot of background work that goes on, and therefore, if you are not attended, if you're not added to the group or something has happened, it is because of the weekend syndrome or of after 5 p.m. syndrome. And if you have not got a recording, so one, if you put it in the group, she is in the group. And now everybody is asking, can we change from Sunday? Now the point of changing from Sunday is very, very difficult, because other days, most of the IAP programs are there. Somebody is having Maharashtra will keep someday, Kerala will keep someday, some courses are there. So we did a lot of homework and we felt it is on Sunday. Those of you can't appear on Sunday, you please please in that case see the recordings. So that's because one, you are comfortable. You want before 9 o'clock on Sunday, then I can do. But 9 means you can go out and come back by 9. Now, is it okay? 9 p.m., 9:15 won't be there. 9 o'clock only will start. 9 is okay. Today, we have written 9:15 for the sake of introduction. Okay, fine. Those of you who have difficulties, please message to me. 9 o'clock Sundays only will keep and freeze that. Now, please remember, no, recordings will be available to you. It will be sent to you. You finish by 1 week, because if you have backlogs, then you can't finish. You should finish that recordings in the next week before the next class comes. After that, again, I have to send next week's classes recordings. You got my point. Now, if you want all the recordings at the end of the course, all the videos, it will be available as a pen drive. Please understand my point. And a pen drive will be couriered to you. You have to contact our office assistant. She will buy and she will send you that pen drive with some cost, because she goes to the shop, buy the pen drive, records, and contact the technical team, and then see that everything is files and are not corrupt. Because after the pen drive and all, nowadays technologies, they will take care, and it will be properly come to you by courier or post. This will be at the end of the course. Let's say around 20 videos are there. All of them you want in one pen drive. Don't think that you are missing them. Is that okay? We will share your recorded sessions for temporarily. But if you want to preserve it in your library forever, you can preserve. But don't use this pen drive for other purposes, unethical purposes, like you copy that and send it to everyone. And I'm trusting all of you and sending. But if you share that to someone, they will start using it for not joining the course. Suppose if I start the second batch, hey, why you want to join? I'll give you the pen drive. Please don't do these things, because even if you get the whole pen drive, you cannot understand the whole science until and unless you spare, join the time, and attend regularly. It's not about teachings and an access to a video. It's about interacting and finishing the course in time. It is not that you are going to listen to me and learn passively. You are going to actively participate and read the contents. Are you understanding my point? And follow up the contents. And that's very, very important. We give you some references and you have to read them. And I'll teach you how to do that. And therefore, it is very, very important that whatever material, slides shared to you, videos shared to you, keep it only with you and be little selfish in this regard. This is only my appeal. You should not be indiscriminately put up on social medias and groups here, there, which is not in my control. However much passwords we use, protective passwords, everything we do, somebody can crack it in the IT. And I will trust you more than anything else in this regard. Is that okay from you? Please type okay. Let's abide by that. See, it's very important. Please keep some sanctity, isn't it? It's our group and it's ours. And let's keep it with us. Huh? Please don't do that. Because I don't even put copyrights. I'm ready to share. I'm ready to share indiscriminately each and everything. But please don't share it for someone. See, you may be good. Someone else may be commercial. And so we can never know who is who until unless we come across the person. And They are also good, but I don't want something kind of things, raw things, dirty things going on at the back end. This is regarding recordings. If you miss any recording, ask our office secretary. She will resend. For example, you are in the 8th class and you want recording of the 4th class. If you request our office assistant Salma, she will send to you recording of the 4th class. Is that work by email? Is this not enough for you? It's more than enough. Ma'am, I want that second class I missed. Now I'm in the 10th class, madam. First 2 classes I want to see again. She will send. So you have unlimited access. Only problem is if my drive from which we have cloud space which you have purchased. I have purchased the cloud space. If that becomes full, then lot of mails goes to the participants. That becomes a dilution factor and I will have problems. And therefore, those sessions which you have missed, you have to read them then and there itself. Don't wait for longer time to be kept online available to you, because I have to upload the next session means I have to free the space. The space available online will also have finite space. It has to be cleared. You got a point. Okay, fine. Then whatever questions are there, I will try to address them. Improvisations, you are most welcome, sir. We want like this, etc. Even the slides of this have got a logo here. Could you see that logo on the right? Whatever you are seeing. In fact, it was not created by anybody else. It was created by me. Do you like that logo? Very simple. Huh? Isn't it? It's the logo for this asthma and allergy course, which is there for you. In fact, I will teach you how to make a logo like this also. No, we'll teach you as well. I want you to not just practice, you have to preach for the next generation. We are creating soldiers of asthma. We have no intentions. All of us are live for some time. We are very finite human beings. So it is the next generation, the next era of pediatricians who should be taking care of the cases. Let's not be selfish. And let me tell you, entire content has not been created by us. We are only the messengers or transformers. Lots of scientists, lots of institutions, lots of people who have put in day and night effort to make an article from where we have referring and we are secondarily giving to you. How great I am in telling that it is my copyright. It is their copyright, which we are copying and sending to you. So therefore, absolutely. But for the original studies are some of the cases that I have seen. Rest of it is also from others. So Hare Krishna, we don't have any rights on anyone else's life and their intellectual property. So all those people, academicians, whose concepts or whose journal articles, books, etc., which contents of which are making me a better teacher for you. Right now here, I with folded hands, I'm acknowledging all of them in one line. I cannot take the name. There are many of them who have inspired me in my life to teach you better. Okay, next. Now, the real session starts now. You are all charged and it will go for a very short time, but I will give you glimpses of what it is. It's for next 20 minutes. Are you all okay? Please type okay. Now you might be getting bored of listening to all these rules, regulations and all. Let's learn asthma, because I didn't want only session on bored of this is that, etc. Now the real session starts now. Okay, good. What is asthma? Let me start with a basic question. Actually, asthma is airway inflammation. It's not a disease. Airway inflammation, you may have an asthma even before the symptoms evolve. You have a disease. You are sensitized. You are subclinical. You have a cough, but not proved. You are getting my point. It starts. It slowly starts. It's a chronic, progressive, persistent, inflammation of the airways. Now, can any one of us peep inside the airway, go inside, see, oh yeah, it is inflamed and come out? No. It will be only reflected clinically in the form of symptoms because of airflow limitation or airway hyperresponsiveness. I think I have summed up the whole of asthma for you. Now, is airflow limitation a must for asthma? Not necessary. Is airway hyperresponsiveness a must? No. Airway inflammation must? Yes. Airway inflammation can lead to airway hyperresponsiveness. Hyperresponsive airways can respond. How they respond? Not bronchospasm alone. It can also respond by cascading the inflammation. Therefore, it becomes persistent and progressive inflammation. Each insult, each episode will add to the corpus of inflammation, my dear friends. And because of the inflammation and edema, not necessarily the major airways, smaller airways, medium airways also become smaller in terms of caliber. You may have wheeze. Hyperresponsiveness can give rise to cough. Inflammation itself can give rise to cough. Please understand. And it is not one-time cough. Next, sir, I get, you think airway is non-responsive? Airway is responsive. How do you know hyper-responsiveness? What do you mean by hyper-responsiveness is? Suppose I can see Dr. Ravi's, Dr. Sujata, Dr. Preeti Puranik, Dr. Satish Kumar, everybody messaging here. Suppose if I ask Dr. Satish, how are you, Pa? Sir, what is this, sir? That is hyper-responsiveness. How are you, sir? I'm fine, sir. Responsiveness. You got a point. Hyper-responsiveness means you can see. Okay. I'll give the best example of husband and wife quarrel. I'm explaining to everything. Let us say husband and wife are not getting on well for some reasons. There is a small but persistent, progressive, episodic inflammation going on. You understand my point? Between husband and wife, which we call as irritation, rubbing, whatever. Now, you are the father of the girl or father-in-law of the boy, whatever. How do you identify the problem between husband and wife? There are two phases of this. A symptomatic phase and a symptomatic phase. It's chronic and evolving. How do you know? Now, you go to their house and ask for a cup of coffee. Let's say you are a neighbor or your relative or your papa of the father, mother, etc. Don't worry. You go there and then ask for a cup of coffee. And she will get, that wife will get a coffee for you. And you say, I need little less sugar, more sugar, whatever, or I need hot, etc. Then husband starts shouting on the wife, why can't you get a hot coffee? What is this? I told you so many times. Now, tell me, this particular line from the husband to the wife speaks of the episode of coffee or chronicity of the problem. Please type. Is it the episode that you are seeing, or is the background chronicity of husband and wife that you are seeing? Chronicity? Are you typing chronicity? Did you understand what I meant by chronicity? Now, I gave the example of a coffee for you because you need to understand. And when some child comes to you with the cough, now I'm repeating for you. When the child comes to you with a cough, you should recognize the chronicity. Otherwise, you'll end up treating cough with bronchodilators or cough syrup. He will not treat the chronicity at all. What he will tell, okay, sugar is less, I'll get some sugar and do. That is not going to solve the problem of husband and wife. You should be a pediatrician with smart eyes to recognize the symptoms beyond symptoms to the diagnosis. This is important. And this is how asthma is underdiagnosed. And this is also how sometimes asthma is overdiagnosed. It could be other way around as well. You could be a bad assessor and you start reading more of the dispute unnecessarily. You are over suspicious also. It's very, very important to appropriately recognize. Now, sir, you continue with the same example. Let me explain to asthma today. Please understand. Now, sir, I went to their house for 10 times for the coffee. 2 times they fought, sir. 2 times I could see husband was shouting on the wife. But nearly 78 times there was no problem. Then, is quarrels common among husband and wife? Answer is yes. When and how you will label a quarrel between husband and wife as abnormal or enough is enough? That depends on frequency and severity of the quarrel. Let us say, instead of shouting on the wife, husband starts hitting the wife. That means severe quarrel. Or instead of occasionally commenting, he starts commenting every day, which means frequency of the quarrel. Therefore, my dear friends, asthma severity is assessed by asthma inflammation is assessed by severity and frequency of the symptoms. Please type L if you like this concept. This is important for you. Sir, why should I ask how many times there was cough, how many times there was wheeze? What you are doing actually? You are assessing by knowing the severity of the symptoms or frequency of the symptoms. You are able to assess the inflammation even without doing bronchoscopy, without doing any tests. This is what I meant by clinical assessment. And this is very, very, very important for every one of you. Now, I have little bit changed your idea as to how you should recognize in your office practice. Now, these kinds of symptoms, you should be able to separate them from the rest of the practice for you. Otherwise, mothers start buying nebulizers at home, asthma or no asthma. They start giving bronchodilators because they want relief. They will get the relief without diagnosis. They'll continue to take the relief without diagnosis. Worsen and present in brittle asthma, difficult to control asthma, overuse and abuse of SABA, which is the current situation in our country. Because sale of bronchodilators is 8 to 10 times more than the sale of inhalation corticosteroids in pharmacies. That means we are prescribing or they are taking. Sir, fine. This is only introductory class. Therefore, I've given you small little what you call spice for you to understand how to come to asthma. Symptoms of asthma are no different from symptoms of other illnesses. After all, airway inflammation can happen both due to infections and non-infectious disease like asthma. Infection will also produce cough, wheeze, breathlessness, and fever. Asthma will also produce maybe less of fever, but it is the quantum of symptoms, frequency of the symptoms, nature of the symptoms, dominance of the symptoms. Let's say a child has more wheeze than cough. A child has more wheeze and breathlessness than cough. A child has only cough. A child has only wheeze but no cough. Can be an airway obstruction due to a vascular ring or a foreign body, or an extrinsic compression due to a lymph node producing a wheeze. It may, or mediastinal shift causing a wheeze. It may not be asthma at all. Therefore, my dear friends, proper symptom analysis is the key, and I'm going to teach you and demonstrate you how we should make. It may appear that, sir, we heard this lecture somewhere, but when you are going through this course, what happens is you are aligning yourself with the diagnosis of symptoms analogy related to asthma, and in whom these symptoms are coming and how they are coming. These are happy children. They are not unhappy wheezers. They look like any other children. In fact, it may be difficult for you to identify an asthmatic children from another child, whereas in a sickness you can easily identify. And in a given child, symptoms are very variable. Mother may say, sir, yes, he has got asthma, sir, but today he had drank some water from the fridge, that's why he has cough, sir. It is not flare-up of asthma. That means symptoms are variable. Sometimes they are severe, sometimes are non-severe. Perception of the mother, assessment of the pediatrician, the way we look at may all be again variable. This variability is further compounded by variable clinicians, variable guidelines, variable epidemiological situations, variable geographical situations. Cough in Delhi is not same as cough in Hyderabad. If you look at the pollution, you understand my point? What has caused, what has not caused. It is very, very important for you to get down and not just ask symptoms, but to even assess symptoms, have a logic of symptoms, presentations, and matching them properly for identification of airway inflammation, airflow limitation, and hyperresponsiveness, which is hallmark of asthma. Now, although husband and wife have misunderstanding, they don't quarrel. They quarrel occasionally, initially. Intermittent symptoms are the characteristics of asthma. Can we get persistent symptoms in asthma? Yes. Persistent symptoms are the features of late presentations of asthma, uncontrolled asthma. You understand my point? But persistent symptoms can also be due to non-asthmatic illnesses. And identifying a non-asthmatic illnesses from a poorly controlled asthma very easy, because history of asthma is very obvious. Multiple nebulizations, frequent visits, response to bronchodilators, everything you know before it becomes persistent symptom. When it is intermittent, it is very tricky, and less frequent when it is much more tricky because you tend to blame it for seasons and other reasons than to airway inflammation, which is very tricky. Identifying early recognition of airway inflammation, labeling asthma is really an art and an act of patience. And labeling it too late is a matter of lack of responsibility on us to prevent airway damage. And therefore, my dear friends, we should be appropriate in placing the diagnosis. Now, heterogeneity of children and variability of symptoms is characteristic of asthma. If somebody gets TB, he gets same severity of cough every day. It can progressively slowly increase. But in asthma, it is not going to slowly increase. It will be high on one day. Next week it will be next episode of flare up. It can be even much less. You can't imagine. Next time it is medium, small. Variability, you understand? Symptoms are variable. Even they are variable in times of the day. More in the night, less in the day. You mean to say inflammation is more in the night, less in the day? Now, when I say heterogeneity of the subjects, somebody is African, somebody is Chinese, somebody is short, somebody is tall, somebody has atopy, somebody has no atopy, somebody is an infant, somebody is an adolescent. Adolescent asthma is different from asthma in preschool. You're getting my point. Heterogeneous. So much heterogeneous that I can't present in one slide entire symptoms of asthma. X patient's asthma has a slide, Y patient's asthma has another slide, Z patient's asthma has another type set of slides for its symptoms and signs. Dr. Pradeep, do you understand what I mean by heterogeneous? Very, very heterogeneous. In all angles, age, sex, ethnicity, region, epidemiology, everything heterogeneous. Even presentations are heterogeneous, non-uniform. This is a slide which is my favorite slide, which I did just yesterday for you to, go through. Please understand the airway inflammation much better. See, this dark orange red is the background inflammation, which is persistent and progressive, goes on happening. This inflammation happens because of the host factors like genetics or epigenetics, which I will tell you later in the next class. But they are because of the inducers of inflammation, like let's say bad environment, a continued exposure. All these things will induce, I would say, in husband and wife quarrel, poverty, lack of job, dowry issues. They are all inducers. You understand my point? They will bring the misunderstanding or paranoid tendencies, personality problems. All these are inducers. But episodic presentations are triggers. Today washing machine did not work, they fought. Is a trigger. Washing machine is not the cause of inflammation between husband and wife. I'm building on the same example that I gave you. The cough is not because of ice cream. Cough is not because of an item in the fridge. Cough is not because of a chocolate, which mother tells. It could be a trigger. Now, why it gets triggered is because there is a pre-existing chronic inflammation. That's why it gets triggered. If there is no pre-existing inflammation, it will not get triggered easily. That's why I'll tell a small, nice tip for you, and all of you should put like at the end. In the beginning, the triggers are viruses. Agreed? Please type AG to agree. In the beginning, triggers are allergies. Uh, triggers are viruses. Now, I'll take a 3-month-old baby. Next concept. 3-month-old baby, 3-year-old baby, and 8-year-old boy, and a 13-year-old, in whom the chronicity of inflammation is more in a 13-year-old, less in a 8-year-old, much less in a 5-year-old, much more less in a 3-year-old, and much less in a 1-year-old. Do you all agree? Agreed or no? In amount of airway damage or inflammation. As the age advances, more exposure and there is more and more damage. More hyperresponsiveness, more irritability, more airway inflammation is going to happen with the age and exposure. Now, in the young age, 2-year-old child, not much chronic inflammation has happened. Not much quantum inflammation is there. Agreed? I'm just giving a scenario of a 2-year-old. Now, he is exposed to a rhinoviral infection. He is going to be asthma in future. Let us say this person gets a rhinoviral infection at 2 years of age. Now tell me, what will be the profile of symptoms? Now he gets the disease. Will it get quickly triggered to produce a wheeze? Pre-existing inflammation is less compared to a 13-year-old. You understand? So he will not at 4 o'clock, if he gets cold, at 4:30 he won't wheeze. Next day he wheezes. You may mistakenly label this as viral lower respiratory tract infection, and you are correct in labeling. Did you understand why there is confusion in under 5 wheezing? Because it is sometimes impossible to separate an illness of a viral etiology from trigger by a virus and causing an allergic inflammation, more so in the young. See, I will just show you this diagram. Follow my arrow. Suppose you are in 2 years up to here. The amount of inflammation is also less. Illness or an asthma behaves similarly in the young age. As the age advances, it becomes clearer. That's why we have transient wheezers. Under 5 wheezers are the ones who wheeze or cough with viral illnesses. Now, as the age advances, one, the viral infections get reduced. Second, their airway becomes irritable. By now, it's a typical before divorce husband and wife. Therefore, the pattern of illness becomes clearer as the age advances, and you can now differentiate a viral illness from a viral triggered illness. Did you like this? Please type L. And I think in a small 2 minutes of my talk, I brought out why there is rawness or lack of clarity in under 5 wheezing. You understand? It is not that we as scientists are confused. It is the very nature of the illness is like that, and why you want to separate. Now, are you going to give inhalation corticosteroids without evidence in an under 5 wheezing? It doesn't make sense. Let me wait and watch. We'll start there. Or, no, sir. He already has got that much of quantum of inflammation to qualify an asthma. Even if he's 2-year-old, I would like to punish him with inhalation corticosteroids. It's a different context altogether. Did you get my point? So, age of symptoms, presentation of symptoms has to be seen with the lens of chronicity. Now, did you all get into your eyes another specs of asthma? I'm gifting you these specs for you. When you wear these specs, you should be able to read the background inflammation. If you are able to do that, you will never do a mistake in diagnosis of asthma. You understood the point? This is very, very important. You should read the airway inflammation. If you close your eyes, you should be able to tell how red are his or her airways. Then absolutely no problem in making a diagnosis of asthma. This is just an introduction for you. More and more will come in future. So don't worry. Again, I'm going to repeat it in subsequent sessions when I'm talking about etiology and pathogenesis. Our understanding of asthma in 80s. I want me to repeat. Everybody's asking me to repeat the session. Okay. Episodes are triggered. And for them to be triggered, there has to be background chronic persistent inflammation. All of you have understood between husband and wife quarrel. Now, fine. I'll repeat. No issue. Now, episodes can be non-severe in young ages because the background chronic inflammation is less. And when there are non-severe episodes, sometimes they are as voluminous or as non-identified close mimic of an actual viral infections itself. That means they look like viral infection only. They don't look at triggered. You will have one day fever, cold and cough in a 2-year-old, even in an asthmatic. You don't behave very, very differently as much as a 4-year-old, 8-year-old or a 13-year-old could do. In a 13-year-old, do you get a cold or like bronchiolitis type of presentation? In a 13-year-old, you don't get it of wheeze, breathlessness. Understand my point? When you get a wheeze and breathlessness in a 13-year-old, it is not bronchiolitis. It is definitely asthma. Why? Because if you get a wheeze and breathlessness following an exposure, it is 100% correct that there is a chronic persistent inflammation. In a 2-year-old, it is quite common. And sir, why can't he also project a hyper responsiveness like a 13-year-old? It is because, my dear, the quantum chronic inflammation in a 2-year-old is much less. And in a 13-year-old, the airways are already completely inflamed. Did you get that? Dhanlakshmi, Pradeep, Chandrasekhar, did you understand? You will have more black money if you are practicing for a long time. More number of mistakes, more number of evasion of taxes as the age advances. A beginner will not have black money only. You cannot know by the way of spending whether he has black money or no black money, especially if he's a beginner. What I meant the same, a viral infection, a viral triggered infection may be difficult to separate in the very beginning. But if you are smart, you are able to do. Generally, viral infection lasts for 5 days. But in his case, the viral infection lasted 15 days. Why? There is allergy. Now, definitely lot of factors. I told you only one sample. I'm going to talk about this more and more later on when I come to etiopathogenesis. The question here is pretty simple. It's not just the age. It is the amount of damage that is a reflection of severity of symptoms or the question of uncontrolled or poorly controlled asthma. And therefore, you have to keep on reading and treating the inflammation, but not the age. Not the age. Beware in young age. Below 2 years, you can't. Somebody asked me the question, and I want all of you to answer. Can a newborn have asthma? Please type yes or no. At least now you should be able to confidently. Dr. Kavita said no. And I'm proud of you. All of you said no. Absolutely yes. Because you can't have intrauterine inflammation of the airways. Fantastic. Excellent. Can a 6-month-old baby breastfed is likely to have asthma than respiratory tract infection? Yes or no? Please type. 6-month-old for asthma? No. Most of you, 80% no. Correct? Now, question is, how many will be yes and no? No, I'll come to that. Don't worry. You have typed yes and no. I agree. How many yes should be there for given no? Ratio of yes is to no. Community prevalence of asthma is 10%. Correct? That means for 10 yes, 10 no, there will be 1 yes. For 100 Wheezers, there will be 10 Wheezers for asthmatic. Did you get the point? Even at 6 months, the prevalence of asthma is a factor which decides whether a given wheeze or cough is asthma or not in that community, in that age group. So, all of you, please don't worry. That means, sir, if I tell yes or no for asthma, how many times I'm correct? 9 out of 10 times you are incorrect if you label it as asthma. And 1 out of 10 times you are correct. That means the positive predictive value of diagnosis of asthma at 6 months is 10%. Did you like these statistics? Please type L. Did you understand? I'm a simple teacher who is going to just make you understand everything that has been taught to you so far. You have been listening to the slides. So prevalence of asthma is 10%. In Kottayam, it is 31%. In Delhi, it is 12%. But what it means to you in your practice is more important to me than what it is. And you must apply, you must think, read between the lines and then move forward. Okay, fantastic. I'll go forward. Our understanding of asthma has evolved. I was talking about the mid part of the slide, that is airway inflammation. But before the airway inflammation became the main part of the talk, there are generation of pediatricians who agree with me. In the past, it was all about bronchospasm. Asthma means wheeze, asthma means breathing difficulty, spasm. You understand? Starting from Aristotle days, Stone Ages till British age, and then 2000. You understand? It was all about spasm, relieving the attacks, relieving, you know, status asthmaticus. This kind of words were used, status asthmaticus. You understand? Now nobody uses the word status asthmaticus. Doesn't make any sense to me. It's a severe flare-up of asthma. Because I don't call it as a status. It is worsening of a pre-existing chronic inflammation. Therefore, I prefer to use the word severe flare-up than status asthmaticus. Did you get the point? Therefore, from the concept of bronchospasm, we move to the airway inflammation and therefore spasm. There is an airway inflammation which is both acute and chronic. Chronic persistent inflammation and over superadded acute inflammation is because of the trigger. It was all about inflammation. The superadded trigger has to be treated with bronchodilators. Pre-existing inflammation has to be treated with steroids. If you have not primed them with steroids, you give systemic steroids. If you are on regular inhalation therapy, you can just increase the dose of steroids for a while. You got the point? That is how we target the airway inflammation with steroids. Now, we move further. What is airway inflammation the hallmark of asthma, or the cause of airway inflammation is the hallmark of asthma? The cause of airway inflammation, that is altered aberrant immunology. That is why asthma and allergy should be integrated, because allergy is the cause of inflammation. You are, because of that allergy, out of 100 patients, you are the 10th 1 in 10, not 1 in 90. Because you have a bad horoscope, you have a genetic susceptibility, you have the immunology system that handles the antigens differently. Therefore, you are 1 in 10, not 9 in 10. Why my child? An asthmatic. Now you can, because the symptoms closely resemble in all 100, to identify the host and immune response, you may have to do allergy testing. Did you get that point? Please type okay, sir, if you have understood. It is not necessarily testing. Even otherwise, asking a good history of exposure would be a clinical equivalent of a laboratory testing. Sir, you may ask me, sir, why skin prick test? Let me answer to you. You have asked for history of wheeze and cough, but yet you do peak flowmetry, spirometry, impulse oscillometry to prove an airway obstruction. Like that, you might have got history of exposure to dust and wheeze, but you want to prove it in the lab, then you do skin prick test. Did you get my point? Now, what was thought an airway disease and an airway spasm was later turned out to be airway inflammation and later a T cell disorder or a systemic disorder of immune response, and therefore airway is secondarily involved. I'll give an example of another disease by which you will understand. There is hepatitis A and hepatitis B. Hepatitis A is a liver disease because hepatocytotropic virus affects the liver and produce manifestations. What are the manifestations of hepatitis? Sir, abdominal pain, vomiting, jaundice. I'm putting it very simple for you. Please understand me. Now, this is acute infection of liver by hepatitis A virus. So if you are an undergraduate student and asked what are the clinical features of hepatitis A, you will say hepatitis A is a liver disease with systemic manifestations. Systemic manifestation means jaundice is a systemic manifestation. Appetite, loss, and vomiting. You understand? Systemic. These are not hepatic manifestations. Systemic manifestations. Come to hepatitis B. Hepatitis B is not a liver disease. You are wondering, sir, what you are talking? You are mad or what? Hepatitis B is a systemic disease of hepatitis B virus, which has predilection to involve liver. Therefore, it has to start with systemic manifestations, arthralgia, slow onset, asymptomatic carriers. 2, multi-system involvement of immune aberration. Hepatitis B, you understand my point? Splenomegaly is not a feature, can be there in hepatitis B. It's not a feature of hepatitis C. Are you getting my point? Therefore, hepatitis B is a systemic disease with hepatic manifestations. It could be cirrhosis, it could be ascites, it could be hepatocellular failure, or a carrier. Did you like this? Did you understand how we think differently? You have both hepatitis A and B virus. Now I'll come to asthma and allergy. Asthma is like hepatitis A. Asthma is a disease of airways, where airways are primarily involved because of inducers. It is because of triggers, etc., and chronic inflammation of environmental, etc., genetic combination. Now, on the contrary, allergy is like hepatitis B. Allergy is not a disease of the lungs. Allergy is a systemic disease. It can manifest with local manifestations like airways when it is referred to as asthma. So therefore, asthma can have an allergic or a non-allergic onset, etiology, and presentation that makes it heterogeneous. If you define asthma as just airway inflammation, which is chronic and progressive, it could be because of allergy, which is in most of the cases. You can have a small segment of asthma not related to allergy. Unfortunately, that child continue to have airway inflammations which are non-atopic in nature. But if you ask me, atopy versus non-atopy, majority of the children have atopic asthma. In adults, females above 40 years, you tend to get non-atopic asthma. In obese, you may get non-atopic asthma. There is an airway inflammation, may or may not be due to atopy. Did you understand the difference between asthma and allergy, which is the part of this course? An allergist will talk to you from systemic lens or viewpoint about an illness. He will not be able to cover the entire body, may not be able to cover the entire airways. Now, a non-allergist or a pulmonologist in practice will look at the airways, which component comes from allergy, which component doesn't come from allergy. Both are correct, and that is what I meant by integration of the course as well as the contents. I'll move forward. Now, this asthma is also having age-dependent management. That means below 5 years, it behaves very peculiarly. And before they become adults, they behave separately. When they become adults, they behave separately. And we will teach you over a period of time how characteristically it differs and how we should manage. It is, after all, a clinical diagnosis. Don't do the mistake of seeing more eosinophils plus wheezing is equal to asthma. Things like that. Did you understand my point? More IgE plus wheezing is equal to asthma. It may be not related at all. Don't read more of the test results and make it a laboratory diagnosis, especially hematological tests. Use your brains and heart properly when you are labeling asthma. There's a flow chart for diagnosis of asthma. This is given in GINA guidelines. I'll just repeat for you. Patient with respiratory symptoms. Are they typical of asthma? First question. If it is yes, detailed history and examination support asthma. Yes, patient is already on treatment or new patient is already on treatment. Perform spirometry and treat asthma. This is the way you go. Suppose patient has symptoms not referable to asthma, is alternative diagnosis confirmed, go for the treatment of it. The patient is already taking the treatment. Identify whether it is controlled or not controlled, and he's on which step of therapy of guidelines. Accordingly, you have to step up or step down. If somebody comes in emergency, the algorithm totally changes. Will teach you how to objectively measure airway functions, which are going to indirectly reflect on airway inflammation. Now, what are these going to measure? Are they going to measure airway inflammation or airway obstruction? PFTs are going to measure airway obstructions, and obstructions are majority of the times because of airway inflammation. Please remember, that's why it is called as chronic obstructive lung disease or chronic obstructive pulmonary disease, COPD. What do we mean by that? It is because of chronic, progressive, persistent obstruction of the airways, which are reversible. The beauty is they are variable and reversible. You can see both of them in the PFTs and we'll demonstrate for you. Allergy testing, I have just given you some initial introduction. The next session, you will have more about allergy. Please understand this entire concepts of allergy. I would request my friend to deliver this lecture for you. I will also be there. GINA, and GINA. If you have not understood GINA, I'm going to show you how to read GINA guidelines. Someone's asking, just so 190, 200 pages, how we should read. I'll make it simple for you. Do not worry. This chakra is very important. Assess, adjust, and review. What do you mean by assess? Assess diagnosis. Assess symptom control. Assess risk factors. Assess comorbidities. Suppose is already a patient, again assess technique of inhalation. Assess whether he's taking regularly, which is adherence. Assess what is his preferences. He doesn't like a DPI or he doesn't like an MDI. Adjust risk factors, modifiable risk factors, and comorbidities. Suppose you treat more of allergic rhinitis, your dependence on dose of inhalation corticosteroids for lungs may get reduced. Non-pharmacological strategies, yoga and others will teach you. Asthma medications can go up and down on them. Adjust the level of the knowledge to the given severity. Very, very important education, skill training for the parents, which will teach you how you should do. Review. How will you review? Reviews like I told you, husband and wife, and you are going to go for the coffee. You review for symptoms. You review for flare-ups, side effects, lung functions, patient satisfaction. These are very, very important. Sir, why we should do this chakra? Every time you review, you are going to reassess, readjust, and re-review, reassess, readjust, and re-review in every visit. Why we should do? We should fit the patient into lowest possible dose of inhalation corticosteroids. That is the idea of the cycle. Cycle is not just putting you have to follow this algorithm. You imagine the cycle is moving, cut. And as in when you come, manage each time. Oh, I was giving 100 micrograms, sir. Now only 50 microgram is enough. Sir, giving daily, sir, alternate day is enough. Sir, I was giving twice daily, once daily is enough. What does that mean? You are reviewing and adjusting. No, sir, even 2 times a day is not enough. I have to add a drug. So, my dear friends, it's all about giving optimal dose of inhalation corticosteroids and matching it with severity of airway inflammation. That is possible from GINA cycle. Did you all understand? Please type U if you have understood. This is very important. Every time you read this cycle and you should understand. Now you, for the GINA document becomes easy for you to read. Okay, next. Now, stepwise management of asthma. What do you mean by stepwise management of asthma? Somebody is not happy with this much. Give more. A dil mange more. Go on giving more. No, don't give more. Give less. He is now controlled. That is with the cycle. So step and cycle are integrated. Steps are like milestones. You have all known, no? Holding the neck, sitting, standing, walking, like that. They are the milestones of asthma. Somebody may have a higher milestone of asthma management or a lower milestone of asthma management. But the process is not like cut. It is a continuous process. See, somebody is already in step 4, but his technique is bad. But somebody has given more dose. Is he really in 4? No. When you assess, review, and adjust, you have found adherence and patient skills were wrong, and the cycle you have adopted. So he moves from step 4 back to step 2. After, now you say 400 micrograms is not required, 100 is enough. So don't say for that patient, you should take 400 but change the spacer. You are all doing that. 200 somebody is taking. Oh, no, sir. After I corrected the spacer. I'll give a practical example how you are doing. Sir, I corrected the technique, sir. Most of us think that we are correctly managing asthma. It is wrong, my dear friends. I'm sorry to tell you. Identify such common mistakes when we see referrals. 200 you are giving, or 100 you are giving with a wrong technique. You have corrected the technique. After correction of technique, don't you think so? Reduction of dose is also a responsibility. How often we do? Like in antibiotics, we know how to escalate an antibiotic. We do not know how to stop or de-escalate an antibiotic, including me. I have done this mistake. I'm not telling you. Type AG if you agree. What I meant by that is, we are generally thinking that we are correctly managing the stepwise management. I will teach you how to even correctly manage this. You might have undergone so many courses. So many times you must have listened to the lectures. But how appropriately adjust the doses, assess the severity, review the response. If you don't know this, then gone. And this is important part, often not taught most of the time. They'll go on telling, nowadays we have added this, you have added that. It's not about adding power. It's about correctly bang on target. That's why I told you, people were asking study material. There's only one study material is enough. If you study GINA guidelines page to page properly, you will not have any problems. And I'll tell you why. Drugs in asthma, inhaled corticosteroids, non-specific anti-inflammatory drugs, some other mechanism drugs will tell you in detail. Devices will cover it for you. Patient education and counseling will cover it for you. Will make you set up an asthma clinic. Will tell you how to manage flare-ups. And I'm going to share the GINA guidelines for you, and lastly tell you how you have to read. And in another 2 minutes, I'm going to close. But most important is listen to me. Do I have those? Now, please let me know if you are able to see this or not. The screen, you are able to see? Because when I share, sometimes it may not be seen. You are able to see? Yes, okay. If you're able to see, then I'll scroll down. Is it moving? Okay. One of you type okay. Moving. One of you type okay. Not moving. Not moving. I'll reshare. Now, is it moving? Please type yes or no. Okay. Fine. Now it's moving. I want to just show you. This is the last part of my today's session. Now I'll just show you what you have to do. This is Global Initiative for Management of Asthma. More than 150 to 200 countries are members of this. And there is a committee which gives you, please understand, global, every word is important, global strategy for asthma management and prevention. It may or may not be addressing your individual needs. You have to adjust and titrate it for given patient. So GINA is not responsible. Follow the guidelines, but customize it for your patient. Very important. But this is uniform consensus updated as on 2025. My problem is how to read the updates. Now, even if you read GINA guidelines 2019, it's okay. You don't have to read GINA guidelines 2025. All guidelines are same. The content is same. I've read and I'm telling you. What is the secret? See, there is something with a document and it just some paragraphs or some chapters are getting upgraded. If you read the older edition of textbook of medicine or pediatrics, it does not mean that you are not reading the textbooks or pediatrics itself. Sometimes older editions are better. You understand my point? Because the recent documents, suppose you want to read about TB, will you read older editions or early, recent edition? You have to read older editions because a lot of clinical material you will get. If you read the recent books, a lot of downsizing of that would have happened on TB. Cases, for example. I'm talking about cases. You understand my point? I'm not telling TB old is better. Please, no, no, no. If you want to read rheumatic carditis, you may have to go for older editions of the books. That's because severe carditis were there. Nowadays, they are less. So, my dear friends, what I meant was, whenever the evolutions happen, at that time, better coverage for that particular topic will be given in those sessions. So, if you feel that a particular topic is not appropriate in 2025, you can just open the Google and see for earlier versions of the PDF. Is this clear? Please type CL. We moved from on control of asthma is best in GINA guidelines 209 has given excellently what is poorly controlled, uncontrolled. Difficult to treat asthma is excellent between 2015 to 2020. 2017 to 20 nicely given on difficult to control or therapy resistant asthma. Did you understand what I meant by that? Very important. Now, you are going to read 2025 guidelines. All right. Now, sir, shall I read pediatric section only? No, you are not supposed to read only pediatric section. Please read complete guidelines, including adults. Sir, why, sir? We are not practicing adults. No, pediatric page may be 150th, but he will not repeat or explain what he has already explained in 36th page of an adult. Did you understand? What? So explanation is not unique to the age. A pediatric section will only cover uniqueness, but he will not repeat explaining what he has explained in the adults. That's why you have to read the whole document. Please type U if you have understood why you have to read adults. Because some definitions, some drugs, he will not repeat again in pediatric. He will refer them in the algorithm and leave. So you have to read the whole document. Now, even if you don't practice adult asthma management. Next, there is always references available. Don't say it is not available. If you open this, see www.ginaasthma.org. If you refer, then you are fine. When I was the chairperson of the chapter, I conducted webinars from the very chairperson of the GINA guidelines. I co-shared the chair session with him. Nowadays it is missing. You can see that missing, isn't it? So Riddle from Australia was one of the uh, speaker in one of the conferences, or I would say webinar, when I was secretary and chairperson. So we did all that. What did I found? What did I learn? The way they look at is excellent. And therefore, if possible, I would invite somebody from GINA one fine day for a session or two for you if possible. Now, the only challenge I have got for most of them is the timing. Timing means, you understand, Singapore or Australia, Melbourne, to US, UK, the timing is a little different. And I would tell you very early, and please adjust on one of the Sunday with a different timing. I would record the sessions as well. Let's see if I can explore that option for you. I'll go back to GINA, how to read this. See, there are abbreviations, introductions. What is new in GINA? Sir, they are not talking about asthma. It's a guidelines and strategy, my dear. They are not supposed to, this is not a textbook on asthma. First, any guideline will update what is new now compared to 2024. So you will have small little problems in reading a guideline compared to your textbook, and you need to be adjusted in your wavelength and frequency. If you want to read more, you should go to cross references, and I will tell you. This is the overview. What is new? Definition, description, diagnosis of asthma in adults, adolescents, and children from 6 to 11 years. Definition, description, making diagnosis, differential diagnosis, confirming diagnosis, how to make diagnosis in other context, assessment. Most important, I told you the chakra, assessment, overview, assessing asthma symptom control, assessing the future risk, lung functions, assessing adverse effects, role of lung functions, assessing severity, how to distinguish between uncontrolled and severe asthma. Next, principles of management, long-term remission, non-pharmacological, how to refer to an expert advice, medications, categories of medications, ICS medications, adults and adolescents, and then track management, children 6 to 11 separately, guided management, self-management. This is if self-management is done means all these things are there. Objectives, difficult to control asthma. I'll go very fast, don't worry. Like this, you are having all the things. There are boxes. I'll scroll down and close. Now, the next point is don't read too much about preface. Acknowledge all these authors. Straight away get into the topic. From here, you should read. Start reading. Every word is important and nice. Suppose you are very poor on the system, go to some printer, take this complete pages. Now, sir, I read something and some reference is given. So page 121, something, etc. There is lots of references in the end. Suppose you don't understand, go to the last page of references, pull those articles from PubMed or from your online libraries. If you want to ask somebody who has subscribed the journal or myself, we will give you those articles. Sir, I want that article to be read. So, but you should read the articles as well. You don't need a textbook now. You have a guideline with references. So the more about those references will be available in the end. Now I'll scroll through quickly to finish. Lot of it is nice. There is no need of any PPT. This is excellent, and you have to just read. You don't get an opportunity to read. The more you read, reread, and whenever you are coming for the class, you know the topics I'll post early. You read that particular section and come. It becomes easy for you to understand the slides and also the presentation. That is because sometimes we think that we have understood, but you might not have understood. And it is very, very important. I'll just go to the last page, which is the reference. Now, let us say I'll go to the 687 reference. Just for the reference, 687. For Foster and McDonald, I have lost in every facet of my life hidden burden of severe asthma. Now let us say you go to 686, prevalence of severe refractory asthma. Now, like this, lots of articles are there which you can read. Around 700 references are there. What does that mean for me is that everything is available in Jina. Now I've taken 1.5 hours just for introduction because I had part 1 and part 2. Next class onwards, please read the guidelines. Can I prepare some MCQs on Jina guidelines and post it so that you will all complete online? If you say yes, I'll I'll prepare MCQs. Now my submission, please understand. Can I use artificial intelligence to prepare the questions for you and I will validate the answers? Is that okay for you? I'll use AI for generation of questions. You don't use AI for answering. Please understand my point. 200 and odd pages. If I have to generate questions on every paragraph, it would be very difficult for me. I will use AI. And I'm openly confessing before you, I'm using AI for generation of these questions because you will start learning them fast. And I think with the availability of technology, we must be using that. Okay. Now, for this day, we are closing. We are welcoming. You are okay to give any suggestions, and we will also tell, okay, somebody, Dr. Sneha is asking personal experiences with asthma. 100% I'll share with all of you, including personal experiences. Many of you are so good, and many of you will become much more good. And I will be very happy if there are mirror reflections of mine in your practice. And if you improve your practice, I don't think we need any other gift than that, because that is when we feel very, very happy and satisfied. The way we are managing, you should be able to manage. Or if you have something better that you are doing, please share with us. Not for the sake of my improvement, it is for the sake of entire group learning. Please share some tricky things. I'll try to find a sponsor, finalize the sessions, etc. Those of you who have got link only on WhatsApp but not on email, please contact our office secretary. Your email could be wrong, and therefore you may face problems. You should get the link on email only. So with this, I'm going to close the session and thank you very much. I'll stop recording.